A patient, aged 59 year, female, married, homemaker, Hindu by religion, resident from Sasaram, Bihar, presented to the surgical oncology OPD with a chief complaint of pain in abdomen since 6 months and distension of abdomen since 2 months. Patient was apparently all right 6 months back. To start with, she noticed pain in the lower abdomen, which was insidious in onset, gradually increasing, dull aching in nature, with no aggravating or relieving factor. Patient also complained of distension of abdomen since 2 months, which was progressive in nature, more on the lower part of abdomen, and these symptoms are associated with loss of appetite and weight loss, which was not measured. However, her usual cloth had become loose. There is no history of fever with chills, rigor, night sweat, no history of nausea, vomiting, no history of urinary complaint, melena, bleeding PR, no history of irregular bleeding PV or vaginal discharge, no history of cough or breathlessness, and no history of headache, seizure, projectile vomiting, and LOC. There is no history of similar complaint in past. Also, no history of hypertension, diabetes mellitus, tuberculosis, and asthma. Patient have a history of hysterectomy during last childbirth due to bleeding at the age of 30 years, but no record of bleeding. No history of similar complaint in family members. No history of any malignancy in family member. Takes mixed diet, bowel and bladder habit normal. No history of tobacco chewing, smoking, or alcohol intake. Obstetric history. Menarche at the age of 14 years with regular cycle, average flow, no dysmenorrhea. Married at the age of 18 years. Patient had 3 children, all by LSCS, cesarean section. First childbirth at the age of 24 years and last at the 30 years. Patient attained surgical menopause at the age of 30 years. All children were exclusively breastfed. No history of any form of contraception. On summarizing my history, a female aged 59 years presented with pain in abdomen since 6 months, which was insidious onset, progressing, dull aching in nature, and distension of abdomen since 2 months, more on the lower abdomen, associated with anorexia and weight loss.
So where exactly was her pain in the abdomen?
Mainly lower abdomen and pelvic region.
हाँ तो इसको लिख मतलब you should write in summary also. And
Yes.
relieved on medication?
Not ma'am. It's a constant pain, dull aching. Patient was examined after explaining procedure and informed consent with adequate exposure in supine position in the presence of a female chaperone. Conscious, cooperative, well-oriented with respect to time, place, and person. Average build, moderately nourished. ECOG 1. Weight 48 kg, height 150 centimeter, BMI of 21.33 and BSA 1.41. Afebrile. Pulse is 84 per minute. Regular rhythm, normovolumic. BP 112 by 70 mmHg in left arm in supine position. Respiratory rate is 18 minutes, thoracoabdominal. No pillar, icterus, edema, cyanosis, clubbing, and generalized lymphadenopathy. Spine examination is normal. On inspection of the abdomen, lower abdomen is distended. Umbilicus midline inverted, all respective quadrant moving equally and symmetrically with respiration. Three lower abdominal scar, 2 paramedian and 1 midline. No dilated veins, pulsation, sinuses, visible peristalsis, hernial orifices are intact, no bulge on cuff, and external genitalia normal. On palpation, there is no rise of temperature and no tenderness.
So you should also mention that stria gravidera. नहीं क्या कहते हैं उनको? Gravidera तो when they are pregnant. Otherwise क्या कहते हैं? What's the terminology?
On palpation, no rise of temperature and no tenderness present. A 25 into 20 centimeter mass felt in the lower abdomen, occupying hypogastrium right and left iliac fossa, right and left lumbar area and umbilical region. Upper and lateral border of the mass is clearly felt. Lower margin could not be palpable. The surface of the mass is smooth, firm in consistency, restricted mobility in all direction. No hepatosplenomegaly. Hernial orifice is intact. No cuff impulse. On percussion, dull node present over the mass. Lever span is 14 centimeter, which start from the 6th intercostal space. No shifting dullness and fluid thin. On auscultation, normal bowel sound and no brood. Then on local examination, vulva is normal. Per speculum examination done after explaining the procedure with cuscos speculum and cervix and vaginal wall is normal. On PV examination, cervix and vagina normal. No palpable growth is palpable. No bleeding, no deposit. Bilateral vaginal fornices and interior fornices are obliterated. And on bimanual examination, a mass of size 25 to 20 centimeter felt in the bilateral adnexa and extending to anterior fornix, firm consistency and restricted mobility in all direction. Digital rectal examination, no piles, fissure and fistula. Anal tone and anal mucosa is normal. Stool present. No nodule felt in the pouch of Douglas. and same mass was felt in the right lateral and anterior aspect of the rectum, bilateral parametry of free. Other systemic examination, breast, thyroid, respiratory, cardiovascular, and central nervous system are within normal limit. On summarizing my case, a female is 59 years, presented with a chief complaint of abdominal pain since 6 months and abdominal distension since 2 months, associated with anorexia and weight loss. And on examination, 25 into 20 centimeter mass occupying the abdominal pelvic region, which has a smooth surface, firm consistency, restricted mobility in all direction, and upper and lateral border are clearly felt, but the lower margin could not be palpable, and the same mass was felt in the PV and PR examination. By above history and clinical examination, my provisional diagnosis is malignant ovarian mass.
What is the DD you have?
No, actually, the patient have a history of giving a history of hysterectomy, ma'am. So,
So what
fallopian
are
tube mass
the
may be-
DD of any mass in the hypogastric?
Well, there is a 4 systems involvement, either from GI or urinary system or genital system or arising from the mesentery. These 4 are the DD, ma'am.
No, this is the organs. You give the differential diagnosis, no?
Yes, sir. Sir, there is a ovarian mass, fallopian tube mass, or mesenteric cyst, urachal cyst, and pedunculated.
Was it possible to
uterine
get
mass.
below the swelling?
No, sir.
Then
Below
how
the
can you say
swelling,
mesenteric cyst? Why can't this be a CA stomach with pelvic metastasis? You said there's
Sir,
significant history of weight loss.
Sir, but there is no history of any GI symptoms like vomiting or bleeding.
Not necessarily. You may not have it. Or this could be metastatic gallbladder also.
But there are no GI symptoms, sir. And the patient
How many times have you seen gallbladder presence as ascites? Just ascites.
The sir,
So-
patient age is 60 years. So I am not suspecting that it is a Krukenberg syndrome, sir, in this
Why?
age.
Why?
Krukenberg syndrome is mainly seen in premenopausal women, ma'am.
Not necessary. Why is it more common in premenopausal?
Because, ma'am, there is every time when the ovulation occurs, there is a raw area over the ovary which takes a malignant cell, and this is the reason of Krukenberg syndrome.
So what, rule it out one by one, why it is not CA stomach with Krukenberg's?
Mainly,
What
sir,
are the
ma'am,
points in against?
ma'am, patient has no there is no symptom of any GI, no GI symptoms, ma'am, that mainly present with no history of melena or bleeding from vomiting or any obstruction, gastric outlet obstruction feature, ma'am.
There is no ascites.
There is no ascites.
Usually such advanced cancer with peritoneal
Patient
spread will
presented
have
with
ascites. And
yes, ma'am.
per vaginally also you did not feel any Bloomer shell for
Pouch of
anything.
Douglas, ma'am. Pouch of.
So what are the findings against CAGB with metastasis? Why not CAGB with
Ma'am,
Krukenberg?
patient have such a advanced case if there is a patient don't have any history of supraclavicular lymph node or pain in the right hypochondrium or jaundice,
So here pain was in the lower abdomen and
lower abdomen.
otherwise they usually complain of pain in the right upper quadrant.
Yes, ma'am.
So why it's not a sarcoma?
Mainly the pelvic sarcoma mainly arising from either uterus or from urinary bladder, but there is a history of
Why
hysterectomy.
it can be a retroperitoneal sarcoma
But it is feel in the anterior aspect of the
or some
vagina, ma'am.
any peanut or tumor chordomas arising from the sacrum, filling up
Some
the
it is-
whole pelvis.
Ma'am, on per rectum examination, ma'am, the mass is felt anterior to the rectum in pouch of Douglas, not in the behind the rectum.
So what mobility this tumor had?
It's
You
a
said
restricted mobility, ma'am.
What
Restricted
in
mobility.
which direction? How did you palpate?
In all direction, ma'am. In all direction, patient that mass is a restricted mobility, ma'am.
See, Kishan, you said this is a hysterectomized patient, right?
Yes, ma'am. Yes, sir.
At the age of 30.
Yes, sir.
You are sure? Did you ask that history that whether the ovaries were taken out with the uterus or no?
Sir,
How
actually,
you so
patient is
sure
not
that
able
CA ovary when patient has already had a
give a
hysterectomy?
proper history, sir. She told that 30 year. This is the actually the patient is not giving proper history for that. She only told that during last childbirth, due to bleeding, patient there is a history of hysterectomy. But on PV examination, cervix is so it may be a subtotal hysterectomy.
So how do you know the ovaries have not been taken out? How can you be so sure of CA ovary then?
Sir, in case of the patient age is 30 years, sir. So mainly at this time, if the ovaries is normal, then uh, patient having no menopausal symptoms, sir.
What are menopausal symptoms?
Hot flush, patient having mainly present the hot flush or
You
You
should
said
say
you said patient has achieved surgical menopause at 30.
yes, sir.
So how do you know? I mean, then you are saying patient had no postmenopausal symptoms. You're contradicting yourself.
you should say that this patient underwent hysterectomy just during childbirth only, no? Just after that, during
Yes, ma'am. Yes, ma'am.
LSCS. That is the
Yes,
history
ma'am.
she gave, no? So you say
Yes, ma'am.
that most probably what I presume is a subtotal hysterectomy was done, and generally ovaries are not removed at
No.
that time, but we need to confirm it on with some investigations
Yes.
because no records howsoever are available. इसीलिए it is important to have a DD. Why is it not a broad ligament cyst?
It may be a broad ligament cyst, ma'am,
Or a simple chocolate cyst?
but such a huge tumor, ma'am, 25 into 20 centimeter. And actually, ma'am, patient presented with a short history with complaining of weight loss and anorexia, mainly towards malignancy.
Also, what age do these things present in?
Patient age is 60 years. Mainly, it is the age of epithelial ovarian cancer.
You are okay, fine. Can it be primary peritoneal carcinoma?
Yes, sir.
Oh, did you put that in your differential diagnosis?
But
Especially when she's had a hysterectomy.
yes, sir.
Especially when she's had a hysterectomy with the status of ovary not known to us.
It may be a primary peritoneal carcinoma, sir, but such a huge tumor.
Primary peritoneal carcinoma will not present like a globular lump.
A huge mass, ma'am.
No, but I'm okay. Patient did not have any ascites, right?
Yes,
And no
yes, sir.
ascites.
Yes, ma'am.
Then it is
It's a
then it is
diffuse
yeah,
disease.
then it is not a difference.
So you should say it's an ovarian neoplasm.
Yes, ma'am.
How can you be so sure it's not a borderline, it's only malignant? There are no features to conclusively prove that. If she had ascites or something, other than weight loss, are there any features to suggest that it's a malignant disease?
Rapid growth, ma'am.
So
Patient
there can
presented
be
with
a
a very
hemorrhage
short
in the
history,
cyst.
but there is no such a pain, ma'am. It is a mild dull aching pain. In case of hemorrhage, patient having a pain.
Most important is the age of the patient.
Age of the patient is suggestive of the malignancy, ovarian malignancy, sir. That is epithelial ovarian malignancy. Sir, then patient came with this blood investigation, sir, done in our gynae department. That CA 125 is 892 unit per ml and serum C is 2.9 nanogram per ml. Rest all other investigations are within normal limit, and patient having a CT scan.
What is VM you have written?
Viral marker, ma'am, that HIV, HBsAg, and HCV, ma'am. This is the CCT of thorax, abdomen, and pelvis. In thorax, there is no pulmonary nodules or pleural effusion. And
How do you know pulmonary nodules in a thoracic screen? You can't see the lung parenchyma here.
yes, sir. But there is no pleural effusion in this uh, uh, scan, sir. And liver is normal, and there is a mass which is mostly cystic, but there is thickened capsule and septas are present with increased vascularity, and patient giving history of the hysterectomy, but this CT scan reveals that there is a presence of cervix and also the part of uterus is present, sir. So it is a subtotal hysterectomy done during that time.
So how did you explain this in your palpation findings? What quadrants it is occupying? It seems to be larger than 25 centimeters.
It's mainly this tumor involvement umbilicus, hypogastrium, right and left iliac fossa, and
So you mentioned
region.
this in your
Yes, ma'am.
palpation findings?
Yes, ma'am.
That
Yes, ma'am.
it's reaching up to the umbilicus? Because such huge tumors will never be Krukenbergs.
And they are unilateral. So Krukenberg is usually bilateral.
Yes.
Lower abdomen occupying hypogastrium, right left lumbar area, and I'm like,
Iliac
sorry, I missed this. Such a huge tumor, it's very difficult. to have DDs.
Then the CT finding is large multiloculated cystic mass of size 18 into 23 into 22 centimeter arising from pelvis reaching up to the epigastric region along the mesentery like arising from right adnexa, showing thick enhancing septation and increased vascularity. Surrounding flat pants are maintained. History of hysterectomy, however, residual uterus cervix is visualized, which is compressed anteriorly and displaced by mass, no significant lymphadenopathy. Then by all this investigation, my diagnosis is malignant right ovarian mass. Probably it's a carcinoma right ovary, FIGO 1A.
So
Mainly
if
jumps in
the question is, if this woman presents with a normal CA125, what will you do?
Sir.
So what are the other parameters or investigations that you should do?
Sir,
CA125 could be normal even in epithelial malignancy,
yes, sir.
or it could be a non-epithelial malignancy.
Sir.
So how will you proceed if the CA125 is normal with such a huge ovary in a 65-year-old woman?
Sir, there is a then for a patient with adnexal mass, there is a criteria, sir, like Roma criteria, over 1 and over 2. Sir.
What
Hello?
are these criteria?
Sir, that Roma is a risk of ovarian malignancy algorithm which considered the CA125 and HE4 to calculate a to know whether it is a malignancy or a benign case. Sir. Same in OVA 1, there are including 5 parameters. That is CA125, beta 2 microglobulin, apolipoprotein A1, prealbumin, and transferrin. These 5 markers are included in OVA 1, sir, in which CA125 and beta 2 microglobulin are increased in malignancy. And they give a reference value that for premenopausal patient it is less than 5, and for postmenopausal patient it is 4.4 to differentiate the benign and ovarian malignancy. And last one is OVA 2, that removing beta 2 microglobulin and prealbumin from OVA 1 criteria and including FSH and HE4, and it gives a single reference value of 5 for any premenopausal and postmenopausal patients.
So now answer the question, what are the investigations you will do?
Sir, routine blast investigation.
No.
CA120.
You have a patient, CA125 is normal. You have described the
Sir.
criteria as well. Now, what are the investigations that you will do?
Sir, that CA125, if it is normal, then HE4,
HE4,
beta 2 microglobulin, apolipoprotein A1,
okay,
transferrin,
transfer it.
and prealbumin.
That's enough.
Yes,
You don't have to do anything more.
sir.
Anything else you can do?
Sir, I can go for a MRI too, sir, for characterization of that ovarian mass.
Good.
It will give more information regarding benign and malignant mass in MRI.
Good. So that was the question. You should have answered it.
Sir.
Why do you need a hint?
You do endoscopy in these patients? Upper GI or lower GI endoscopy?
Patient having no symptoms of any GI symptoms, sir. So it is not necessary to go for a GI endoscopy.
Suppose this lesion would have been bilateral.
Sir.
Then would you done an endoscopy?
Yes, sir.
Why?
Sir, because bilateral tumor of the ovaries are mainly found in familial cases, a hereditary disease, that metastasis from GI or
So
any other.
what are the imaging differences between a primary ovarian cancer and a Krukenberg tumor?
Sir, mainly Krukenberg syndromes mainly present with a bilateral mass.
What is the imaging characteristics? How do the ovarian mass in a primary versus a ovarian mass in a Krukenberg appears on CT or MRI? The answer would have still been no, because
Sir.
on imaging characteristics you will know whether it is a primary ovarian or a Krukenberg tumor. Krukenberg
Yes,
is primarily a surface deposit,
yes,
while the primary ovarian arises from the ovary itself, with capsule being intact and normal. So you don't see a breach in capsule in a primary ovarian cancer, especially 1A.
yes.
When does the breach occurs?
Sir, sir, in figure 2A and beyond that.
Yes. So you have made a diagnosis. So what do you plan to do now?
Sir, my plan is to go for a staging laparotomy for this patient, sir.
The staging laparotomy.
Uh, if that ovarian mass which is not biopsy proven and it's an early stage disease. So in this, so I am planning for staging laparotomy by which we remove that bilateral ovarian mass with BSO, then transabdominal hysterectomy with pelvic lymph node dissection, omentectomy, and ascitic fluid analysis, and take a
So what
peritoneal.
is the correct terminology? Is it staging laparotomy or it has some other terminology?
It is primary debulking surgery, ma'am. Staging laparotomy or primary debulking surgery.
What kind of omentectomy you do in this?
Total omentectomy, sir.
Patient had omental deposits in this case.
No, sir.
You would-
Pandey, what is the right terminology? I mean, I don't read this often. It's like cytoreductive surgery. What is it exactly called?
It is called staging laparotomy only
Acha.
because it is it is a staging procedure only. It's a primary debulking, yes, but with the staging procedure.
Cytoreduction that we call is no longer used.
In cytoreduction, only the tumor is removed. Here you are taking multiple biopsies and sampling from areas which are clinically normal to diagnose the microscopic disease. Like the omentum can be normal, but you are taking it out. The pelvic peritoneum, the paracolic gutter, the subdiaphragmatic area, you are taking biopsies from there. So even though they are clinically normal, a biopsy is taken from there to detect the primary disease.
Yes,
And
that I know, but the confusion was about the terminology. Anyways,
uh,
Kishan, you answered Professor Pandey's question. You were answering
Yes,
what all you do.
ma'am, I'm going for the
Momentum
removal
is
of
normal, you would still remove a total. You'll remove the total momentum.
Yes, sir. Completely staging laparotomy has to be done, sir.
Isn't it only momentum in case there are no nodules? It's not there's no peritoneal disease.
Sir, actually, there is one study, sir, that Young et al., which shows that if in a proper staging laparotomy, the stage will be upgraded in 31% patients, sir. So, it's a complete staging, sir, for patient.
so what is the rationale of doing paracolic gutter and infradiaphragmatic sampling?
This is, sir, mainly due to the ascitic fluid circulation, sir. When patient having ascites or peritoneal fluid,
If
uh,
patient is not having, then also you do it.
yes, sir, because there is a
So what is the rationale?
the normal amount of peritoneal fluid is there in the abdominal cavity, sir. And in a most dependent portion, it is accumulated in the pelvic region. But when the respiratory movements occur, the negative pressure generate in the thorax. So when this fluid, the way of this fluid is from the pelvis through paracolic gutter to right subdiaphragmatic space. So these are the spaces where most of the malignant cells are resides, and there is highest chance of peritoneal metastasis in this field, sir.
Where does it go from the right subdiaphragmatic space?
Right sub there is a stomata in the diaphragmatic surface, sir. If the fluid is too much and the intra-abdominal pressure is more, it may go to the pleural cavity by this way. Otherwise, when due to Morrison's pouch or during most dependent portion, again it's come to the pelvis, sir.
It doesn't go anywhere else. Huh?
It may circulate throughout the abdomen, but most common path is this.
I understand the most common path is this, but what happens to the third compartment fluid? It never goes into the main circulation. How does it go into the main circulation and comes out from there? Third compartment fluid, no?
Yes, sir.
So it has to go back into the main compartment and then comes out
By
again.
absorption
does
from
it
the
go?
absorption from the peritoneal surface, lymphatics and that capillaries, sir.
I think you should read peritoneal fluid circulation.
Will you do an appendicectomy in this patient?
No, sir. If during surgery, if appendix is normal, sir, there is no need of doing the appendicectomy.
What is the concept of subperitoneal space?
Not sure about that, sir. I have not read.
So you
Any
got
role
to,
of frozen section?
Ma'am, during but after removing of the tumor hole is out from the abdominal cavity, then we'll send for the frozen section, ma'am. If it is a benign condition, then no need for go for a staging laparotomy proper.
So the correct terminology is comprehensive surgical staging as per NCCN. I just opened it up. What is the extent of lymph node dissection you will do in these patients?
In this
Assuming
case,
it's a malignant case. Yes.
if it is a malignant case, ma'am, it is an early stage disease. So I will go for a systemic lymphadenectomy proper removal of that bilateral pelvic lymph node and the parietic lymph node, ma'am. In this case, early
So
stage disease.
what are the boundaries of PLND?
Ma'am, superior than the renal vessels, ma'am, and lateral ureter.
Pelvic,
And,
pelvic. PLND is pelvic lymph node dissection.
That is the boundary. The lateral boundary is
Hmm.
the genitofemoral nerve, ma'am. Medial is ureter. Above is the bifurcation of uh, iliac vessels, and below there is the angular vein.
Angular vein.
Circumflex iliac vessels, sir.
Why do you want to do lymphadenectomy when most of the evidence is against it?
Sir, actually, for early stage disease, the systemic lymphadenectomy is a part of staging laparotomy. Because a proper staging laparotomy, as I said, this young adult shows that 31% increase of the up staging in the early stage, sir.
Upper stages to what?
Sir, from if any lymph node is positive, then directly it is
So
from
if you
1A
have
to
1A,
3A, 1A to 3A, from stage figure 1A to 3A, sir.
so in the Young et al. Series,
Yes, sir.
what was the major upstage?
Mainly, sir, stage 3C, macroscopic extrapulmonary, extrapelvic, macroscopic extrapelvic peritoneal disease.
So it is not nothing to do with lymph nodes, no?
Yes, sir.
What is the rationale for doing lymphadenectomy? That's the question.
Sir, to know
Young
the
et al.
staging
Young
and
et al. Series
yes, sir.
upstaging is not because of the lymph node involvement.
Yes, sir. But if the lymph node is if the lymph node is positive, the patient is figure 3A. So we plan for a adjuvant chemotherapy for this patient, sir.
What are the trials that have shown the advantage of para-aortic lymphadenectomy?
In his staging, sir, only for staging, there is no survival benefit or progression-free survival in lymphadenectomy, sir. In we shown in Lion trial and Penesi et al. Trials.
Hmm.
But it has a role of staging in an early stage disease.
Not going to alter the progression-free survival even if you give adjuvant chemotherapy.
Yes,
So
sir.
what are you altering?
Prognosis, sir. We have to explain the patient about the prognosis, because if patient is having figure 1A, the 5-year survival rate is around 80 to 90%. But if a patient presented the stage 3, the 5-year survival rate is 27%.
So just to let the patient know, you will do an extensive procedure.
Sir, even if I am not go a proper staging laparotomy, if I consider patient as a figure 1A, I am not giving a adjuvant chemotherapy, so the survival is worse than as usual which is seen in figure 3, sir, in adjuvant with adjuvant therapy.
I didn't get you.
Sir, if I am not going for lymphadenectomy and I consider patient as a figure 1A disease,
Yeah.
then I will not give any adjuvant chemotherapy. But if I am go for a systemic lymphadenectomy and patient comes as and if comes as a lymph node positive, then patient is going for a figure 3A.
So
Then
what
I'm-
percentage of stage 1A patient will benefit or will have their prognosis changed by doing a para-aortic lymphadenectomy?
What percent of stage 1A you will pick up occult meds, occult lymph node meds?
15%, sir.
Ooh.
5%. 5%, sir. 5%.
So that means 95% of the time you will be doing an unnecessary surgery, which is right or wrong?
Sir, if I give a benefit for 5% of patient, then
And what is the complication rate? 95% where there is no benefit, what will be the complications?
there is in the patient who have a who went for a systemic lymphadenectomy, the complication rates are more, sir.
And what are these complications?
So, ma'am, mainly patient presented with a chyle leak or bleeding, more time of surgery, blood loss.
What is
Also the
90-day mortality? Have you read the clinical trials on para-aortic lymphadenectomy? What is the difference between the mortality rates and complication rate between the patients where para-aortic lymphadenectomy was done versus where it was not done?
so there is one study I remember that shows that there is 7 to 8% mortality in patient having a para-aortic lymph node dissection, sir. And normally, in patient who have not parietic lymph node dissection, the mortality rate is less than 1%,
So how much percent difference is there?
around 7 to 8%, sir.
Yeah. In the series of Harter, it was 6.5%. Percent of the patients, or prognosticate 5% of the patients doing unnecessary surgery in 95%, of which 6.5% will die as a result of your procedure.
Yes, sir.
Are you justified?
No, sir.
So you have not completed the list of complications of lymphadenectomy.
Ma'am, first is bleeding, injury to the surrounding structure like blood vessels or ureters. Also, patient having a chyle leak.
And
And
what is a lymphocele?
there is collection of lymph in the abdominal cavity, ma'am.
Any major nerve that you can damage in the area?
Yeah, hypogastric plexus, ma'am.
It comes right during in your dissection plane.
I'm saying hypogastric plexus will not come in the area of when you're doing.
Yeah, he is going up to the paraiotic. You look at the pelvis. Is there some nerve that we identify all the time?
That nervi urgentis, ma'am.
अरे वहाँ
Like,
कहाँ पहुँच गए? Obturator fossa में कुछ दिखता है?
Ma'am, obturator nerve, the pelvic lymph
So
node
wha-
dissection.
So what is this obturator nerve? It's motor, sensory. What kind of nerve is this?
It's a sensory nerve to thighs, ma'am.
Is
What
it
do-
complete? Sorry. Yes.
You finish. You finish.
So what is the root value of obturator nerve? Is it only sensory? Are you sure? If it is only sensory, like genitofemoral, I wouldn't care.
Ma'am, it is a mixed, ma'am. Mainly the root value is L2, L3, L4
So it has motor also.
motor component also.
So what happens if you damage it?
There is a loss of sensation into the thigh, and also the internal rotation of the thighs, internal rotation flexion of the thigh is impaired.
Wrong. Which muscles does it supply?
Obturator internus, sir. Externus.
It is the hip adductor or abductor.
It supplies superficial adductors. So not
You
rotation.
should not.
Adduction and flexion of the.
And what is other thing that you can damage in the obturator?
That is the internal, like that is the veins, ma'am.
In the same context, it was that when you have how does the patient present when you have bilateral obturator nerve injury?
That both the hip or abducted position and
You read this question. You read this.
yes, sir.
Yeah, and one thing more you missed is DVT, thromboembolic. Yeah, pelvic vein
Yes, ma'am.
thrombosis also occurs.
Suppose this is 1C on histopathology, then what will you do further? The washings were positive and this is an tumor
Sir,
restricted.
sir, first I want to see the histologic type of the that tumor. Sir. If it is a high grade
Clear
tumor,
cell.
yes, sir.
It's clear cell high grade.
Clear cell, and then I will go for adjuvant therapy, sir. Adjuvant chemotherapy for the patient. That is mainly 6-cycle carboplatin and paclitaxel.
What is the role of intraperitoneal chemotherapy?
In this patient, if it comes as a one, even in comes as a 1C, there is no role of intraperitoneal chemotherapy, sir. Mainly intraperitoneal chemotherapy has a role in the patient is stage 3 and stage 4 disease, sir.
What form of intraperitoneal chemotherapy are we talking?
IPEC and PIPEC.
Anything else is there which was kind of previously tried, and I mean gradually the world moved on to HIPEC?
That is a cisplatin during surgery, that 100 milligram cisplatin is instilled in the abdominal cavity and close it.
So what is the rationale of this HIPEC?
Mainly after a complete complete cytoreduction or optimal cytoreduction, there is
First you
even
define optimal cytoreduction.
that is a now according to Eisenkopf study that optimal cytoreduction is optimal cytoreduction is no macroscopic disease in the abdominal cavity, considered as a optimal cytoreduction, and NCCN, that is less than 1 centimeter of the residual disease.
So how do you treat those small mets that happen in mesentery?
That is treated by that intraperitoneal chemotherapy. It is a
No.
first is the all
Suppose there are lots of small deposits, miliary deposits, which you cannot remove from the intestines.
total peritoneectomy, ma'am.
That way you will
Yes,
do
sir.
of the parietal peritoneum. This
Yes,
is the
ma'am.
visceral peritoneum.
Yes, ma'am. then that
How will you treat them?
then intraperitoneal chemotherapy is or if it is resectable, ma'am, it is that small nodules are present in a localized section. I will go for a resection of that uh, structures, ma'am.
Okay, localized, so you can do distal
Yes, ma'am.
gastrectomy, cholecystectomy, LAR, everything. But
Yes, ma'am.
suppose it's scattered all over the abdomen. How will you achieve optimal CRS? So all deposits on visceral mesentery cannot be excised.
Yes, ma'am.
So you leave them as such.
Ma'am, actually, that intraperitoneal chemotherapy is role only when the CC score is 1, ma'am. That is, if the disease is less than 2.5 millimeter, then only that HIPEC or intraperitoneal chemotherapy will help. Otherwise, it has no, there is no
So
beneficial
I'm
effect.
just asking you, how will you treat those miliary deposits on visceral peritoneum? Sarah, you have done a total peritoneectomy, you have done an LAR, everything is gone, but there are still lots of nodules scattered all over the small bowel mesentery. So there are ball tips,
Organ,
cautery
yeah,
tips,
organ plasma.
or using ball tip cautery as far as
Yes.
possible, because all that cannot be stripped.
Yes, ma'am.
So what you come to the rationale of HIPEC? What were you saying?
There's a hyperthermic intraperitoneal chemotherapy.
So what is the
chemotherapy.
temperature?
That is mainly 41 to 43 degree of centigrade. Ma'am, it will increase the permeability of chemotherapy. Also, it's direct. The heat has a direct toxicity to the tumor cells, and also some chemotherapy has a synergistic action with the heat to kill the tumor cells.
And in short, tell us what are the complications of HIPEC?
Mainly hypex have a and mainly presented with GI symptoms. Our patient have adhesions, fistula, renal system, renal toxicity, and hepatic toxicity, obstruction of small bowel obstruction. Also, there is a
Paralytic
ma'am.
ileus.
Paralytic ileus, and due to the high concentration of the chemotherapy, it may go for a neutropenia or thrombocytopenia.
So you mentioned PIPEC. PIPEC, is it used in resectable tumors or it's used only as a palliative procedure?
Ma'am, mainly after removing the after optimal cytoabduction, the pipette can be used, ma'am.
So there are studies to show PIPEC in after complete CRS.
Yes, ma'am.
What's the
Name
full form
a
of
few
PIPEC?
studies.
There is a pressurized intraperitoneal aerosol chemotherapy.
Few studies which say that it is done.
Yeah, because tell us, because I don't know. I thought it's only for use for palliation.
Ma'am, I have read that intraperitoneal chemotherapy, but I am not sure about the studies in pipette, ma'am.
But you confidently said just now.
Yes, ma'am. Yes, but I am not remember the name of that study, ma'am.
Do HIPEC in all patients of peritoneal carcinomatosis?
Sir, only the patient in which the CC1 score is achieved, sir.
What is PCI?
This is a peritoneal carcinoma index, sir. In HIPEC therapy, the abdomen is divided into 13 compartment, and each compartment, if the according to the size of nodule, there is a number, that is a lesion score 0. If the size is, there is no macroscopic disease, then LS0. LS1 is considered less than 0.5 centimeter. LS2 is 0.5 to 5 centimeter, and LS3 is more than 5 centimeter. So we considered the highest size, largest size of the nodule in every 13 compartment and sum all the numbers.
Okay. So
Yes, sir.
till what index the surgery is indicated, and after what the surgery and HIPEC is supposed to be ineffective?
Sir, for colorectal it is a 17, and for stomach cancer it is a 12.
And what is for ovary?
If I go for consider that CC score less than 1, optimal saturation can be done for that disease. I can go for any PCI, sir. The optimal saturation can be achieved with CC score less 1 or less than 1. Then in any PCI index, I can go for a HIPEC surgery, sir. HIPEC procedure in ovary.
But normally the in the ovary, the average HIPEC score, average PCI which is reported is about
Sir.
13. The median is reported at around 13.
Yes, sir.
But if you can do a complete debulking, you can always go for a HIPAC in ovarian cancer, but not in other cancers. So that is the difference between the ovary and the
Colorectal and stomach.
colorectal and stomach cancers.